Hey, what's up, everybody? Welcome back. And we're going to talk about my personal favorite subject, which is perioperative nursing. Now, this is a short lecture because we're not going to get too deep into the weeds on this because you're first semester students and you'll have a much more in-depth lecture in your fourth semester. But let me just take you through the wonderful world of periop. All right, so perioperative areas, that explains the areas around the operating room or procedure areas, right? So that means preoperative, intraoperative, and postoperative care of any procedure. And when you're in that environment, safety is one of the most important things of note. There's about a 1 in 15,000 chance that you will have a wrong site surgery when you go into surgery, right, in this country. So that's not although it's not a lot, it's certainly something that is concerning. And so there's a lot of safety measures around that, right? Not to mention infection, which there's about a 1 in 100 chance that you'll get an infection, depending on what caregiver, maybe 1 in 200. So these are things that, maybe they're minor ultimately, but they can be catastrophic. And so these are things that you want to be aware of, and any preventable error, we're always going to be trying to prevent. So we focus on things like hand hygiene to prevent infection, good scrub attire practices. And then we also look at things like instrumentation and surgical sponge counts and things like that. And we'll go through that in a few minutes. One of the things that you'll see in the OR and perioperative areas is the AORN is referenced a lot, and they have their guidelines that they publish every 4 years, and that gives us a set of standards that we go by, and these are adopted across the country to help minimize patient care adverse events. You also have the Joint Commission, who publishes national patient safety goals every year. And there's always 1 or 2 or 3 issues that are related specifically to the OR. One of those is commonly preventing wrong site surgeries. Another one is preventing retained surgical items, surgical infections, communication between caregivers, et cetera. And then we have our National Priorities Partnership and the Institute for Healthcare Improvement. I went to a training for the IHI Institute Healthcare Improvement in 2013, and it was called the Patient Safety Executive Course. And it was a 5-day course in Boston, and it was fantastic. It took me all the way from the ideas of continuous improvement models all the way through highly reliable surgical teams and the idea of reducing variation. Put me at that point in the forefront of the knowledge of how people can improve their processes to reduce the events of adverse events. And so I was really fortunate to be able to do that when I was working for Kaiser. And that has driven my practice ever since, as far as trying to be an advocate for quality and safety and reduce errors. All right, so never events. A never event, we hear about, well, if you haven't heard yet, you will hear about it no matter where you work. Never events are things that are not supposed to happen, right? Never, meaning it's never supposed to be the situation. So it doesn't mean it never happens. It just means that it's always avoidable. So surgery on the wrong body part should be avoidable through the universal verification process. Surgery on the wrong patient, again, verification should prevent that. Wrong surgery on a patient, so doing the wrong thing you're not supposed to do, also part of the universal protocol. Deep vein thrombosis or pulmonary embolism. Now that's a different one, but that pertains to how we manage the risk of those things, because when you go under anesthesia, or maybe if you even have an orthopedic surgery, there are certain risks that come along with coagulation problems, and how do we manage those? We have a set of standards that we follow. Foreign body left in the patient after surgery, same thing. It's all done through the universal protocol of verification. And then finally, surgical site infections after certain elective procedures. And we monitor these rates publicly, and they used to call it the SIRS project. Now it's called the SIR, surgical infection rate. And so these are things that we monitor based on national averages to determine whether our program is doing better or worse than these infection rates. And then if you're above that, you initiate research on how to reduce that. So classifications. So we have different surgical specialties based on body systems. Okay, so, very few surgeons are able to do surgeries, every surgery, right? General surgeons do quite a few, but in many cases they're mostly contained to the thorax. And then we have other people like orthopedists, podiatrists, urologists, neurosurgeons. What else am I missing? Heart surgeons, and I can't forget my ear, nose, and throat doctors, and probably 10 more that I haven't remembered, right? Pediatrics and dentists and all sorts of things. And so they're all specialized by a group of body systems. The purpose of classifications is to specialize and increase the quality of those areas. Also to focus our resources in a certain area. So for instance, if I had a specialty care hospital that only did orthopedics, I don't need all of the supplies and materials that a multi-specialty hospital will have, right? So we think about those classifications in order to deploy resources. And sometimes resources are the specialties of the nurses, right? You have nobody is an expert in everything in the OR. And so there are nurses that have certain specialties or work more cases in certain multi-specialties. The degree of urgency. So we do something just like the ER. It's a little bit different of a triage system, but we do use triage. And so there's different levels. So you'll see number one, you'll see elective. That means there's no risk to the patient of their overall health, but it needs to be done. And maybe it needs to be done only because for cosmetic reasons, right? And then you have, there's a couple different like delayed. And so that means it's important, but it can wait a little bit of time. And then you have urgent, which is usually, and we have urgent and emergent. So emergent means emergency. And so usually an emergent patient is they need life-saving care within 4 hours of approach, or something major like a loss of life or limb may occur, right? So that might be your sight, that might be a finger, or it might be your life. And then the urgent is in between. So a lot of times that will be more than 4 hours, but up to 24 hours. And then the degree of risk, we also manage that as well. That doesn't by itself classify you, but what it does do is it helps us understand the prioritization within your degree of urgency to make that happen. Because it's not just a line of a queue of patients. It's always sorted. In the operating room, we have wounds. So when people come to us, in order to determine where that wound was, if it is contaminated and has an infection, in order to help us understand where that occurred, most likely, then we classify wounds when a patient comes into the OR. If they already have a wound and it's open, we're going to classify that, okay? Now, if we open the wound and we incise it originally, then of course that's a clean wound, and that's not contaminated by, it should never be contaminated. But if somebody comes in to us with a wound that was, for instance, opened up as a laceration, that's going to be a contaminated wound. Okay, we consider it contaminated. If it's a clean contaminated wound, it means, for instance, it was something that was a little bit less risk of contamination. Contaminated wound might be you had a car accident and you had a puncture or something like that. Okay, so that's clearly contaminated. Another example of that is some sort of incision that we do in the bowels or in the perineal area. That's always going to be considered contaminated, even if we initiate it. And then you have infected wounds, which are, of course, always going to be infected. And so that's the baseline. And we initiate protocols to try to reduce that, but not prevent it. All right, so pre-op. Pre-op's pretty important in the OR because those are the steps prior to going into the operating room, and this is our chance to optimize the patient for surgery, recognize the possibility of error, and also prepare the patient for what is ultimately, in some cases, a life-changing experience, right? So the things that we look at age, we look at the type of wound, pre-existing conditions. So we do a full history and physical of the patient. That's required within 24 hours of the patient. There's there's actually no requirement in some of the regulatory bodies for the date of a history and physical, but usually it has to be done within 30 days. And then there has to be an update to that history and physical within 24 hours of the surgery. So that may be a very short process, but it's a confirmation that there's nothing that's changed, and that's only done by the surgeon or a licensed independent practitioner. We look at mental status. Are you competent to undergo this? If you're undergoing some sort of a procedure that requires that might be related or contraindicated if you have a history of drug abuse or something like that, that might be something that we're trying to screen for. As well, what kind of medications are you on? There's many medications that will result in an increase of risk of things like coagulation problems or complications. And so blood pressure, diabetes. So we try to manage those carefully. We want to understand your personal habits. Are you a smoker? What kind of exercise do you get? What condition is your cardiovascular system in? Because all of those things are going to be minimally compromised, and we want to understand what kind of risk there is. And then finally, do you have any allergies? So is there anything with your medications we should be aware of? Have you ever had any issues with allergies or any other reactions to surgery? Maybe you have a lot of nausea. Maybe you require more than the usual amount of pain medication, or maybe you're very sensitive to that. Those are all questions we try to obtain. When we do an assessment, essentially what is happening, there's something called a nursing data set assessment. And you'll maybe hear this in other specialties as well, but a nursing data assessment is nothing that's more than a pre-organized standardization of questions that you ask. And oftentimes the terminology the nomenclature is dictated as well to help us study it so that everybody's doing it the same way. So we do a focused nursing history on every patient. We do a focused physical assessment, which means the focused physical assessment means we don't look at your neural status in your upper extremities if we're operating on a toe, right? At least preoperatively. We might test that postoperatively for strength or for some other reason. We do similar diagnostic testing, and we have a grid of preoperative testing that's based on your history, your age, your pregnancy status, things like that. That would include things like a CBC, a urinalysis, EKG. We don't do chest x-rays for every surgery, and we don't do EKGs for every surgery. But, for a lot of them we do if it's pertinent. And then we might do a type and cross for blood in case there's a risk of severe bleeding. We might do a fasting blood sugar to make sure that your blood sugar is not too low before we take you in or not too high. All right, so the way we apply a nursing diagnosis in preoperative is it's individualized. It's often focused around anxiety, fear. There's a lot of fear when it comes to surgery, of course. We'll talk about ineffective airway clearance because whenever you undergo anesthesia, your alveoli are compromised and you stop breathing for yourself. So we're always thinking about that. Sleeping patterns can be altered because you're essentially asleep. And so sometimes you'll have pain afterwards as well. So you might be restless. And so we want to understand what that situation is for you on a normal state as well. Are you going to be able to cope? I've had patients that are coming in for a bilateral knee replacements and aren't aware that they're going to need somebody to care for them. Well, that's clearly a risk that they're not going to be able to cope with that situation, won't have adequate resources. Latex allergy reactions. Is somebody allergic to latex? Because there is latex in our environment. We try to go latex free, but there are old remnants of things that we use rarely that are often not made latex free. And so that's always a risk. And then we understand what that reaction would look like. And then we look for deficient knowledge areas, because before they go home, we have to make sure that they're educated to have the best chance to take care of themselves. When you're taking care of older adults, they have unique risks. So their bodies over age changes. They have more chronic illnesses. Their physiologic ability, their functional reserve of all of their organs they're less resilient to trauma or like change in their homeostasis. They are at greater risk for drug toxicity because of their kidneys and liver maybe aren't functioning at 100%. And then when it comes to anesthetic or any drug that you get, there's always a risk of toxicity. So we're always taking a close look at that to make sure that we're not taking unnecessary risks and that we're intervening quickly if something happens. More pre-op interventions. We have standardized interventions that we have across the board. Preoperative coordination from the primary care clinic to our pre-op nurse to anesthesia. All of those things trying to understand what the status of the patient is and preparing the patient for surgery and what they're going to need to do prior and then also afterwards when they go home. And we do a lot of teaching in perioperative medicine. Okay, so I talked about the history and physical. Before you go into surgery, the surgeon needs to do that history and physical. Also, the surgeon conducts a surgical consent. And this can be done, sometimes it's up to 6 months prior to the surgery, but it's a mutual understanding between the surgeon and the patient. And it's an informed consent that basically says, I give you all the information for what the risks and benefits are. You indicate your understanding and that you desire to move forward. This is a conversation. It is not, the paperwork does not indicate the conversation. The paperwork is a confirmation that we all agree the conversation occurred. And so on the surgical day, the preoperative nurse might be in charge of witnessing this. Often the pre-op nurses may be confused about what signing that means, and they might have concerns. You're only signing the fact that the patient agrees that conversation has occurred effectively. So the nurse is responsible for verifying that, and then the informed consent has to have the patient understanding that communication and that it wasn't coerced, and they give their signature to indicate that. In pre-op teaching, what's going to happen? Well, we tell patients exactly start to finish what it's going to be like. That helps decrease anxiety. We talk to the patient on how to participate in that care, or the caregiver. Hey, you're going to go home. They're going to post-operatively, you'll be in the hospital for about 6 to 8 hours. They're going to get you up and test you with physical therapy. If you can get up with walking assistance, they're going to send you home. The first 8 hours, you're going to be under pain medication extensively. After that 8 hours, we want you to rest that first night and then wake up. Want you to get up with your walker and do that at least 3 times a day. You're going to most likely have soft foods right away, but if you tolerate it, you can progress, right? You understand what that's going to look like. And we try to paint that picture for people so that they have the ability to be prepared and also that it's familiar with them when they go through it. Common feelings and concern. It's not uncommon for people to be very concerned. I work in peri-op, and I tell people that if you can, avoid the knife, try to, because it's unnecessary risk if you're not. But at the same time, it's a very safe environment, very dedicated people, and a relatively low risk of complications. But it's not uncommon for people that are nervous to come into their preoperative visit and not remember very much at all. So we have to understand that that's not the ideal place to learn, right? And so we're aware of that in peri-op medicine. And so we will accommodate that in certain ways. We use videos, we use a lot of paperwork to confirm what we've told them and things like that. What the patients and families can do to prevent surgical sinus infections. So what we tell you to do when you get home is very important. A lot of times if patients they don't follow the instructions, maybe they take their dressing off early, or they take a shower too early, or they keep showing everybody their wound, that can be something that could create an infection. So we want to follow those instructions very carefully. And when we're talking to older adults, it's even more important, because all of those resources that a younger person has, they're going to be less so in an older adult, and to some extent in children. All right, so when in pre-op on the day of surgery, we prepare the patient for surgery, and there's some things we think about. Okay, we think about making sure their temperature stays normal. The operating room is very cold and they're exposed during the procedure. And so we want to make sure that they are not too cold. When they come out, if their temperature is too low, or if they're shivering in the post-op area, number one, it's associated with more pain and lower healing when they come out. Also, the more that they shiver, they're using oxygen. So that consumes oxygen instead of dedicating that towards their recovery. Number two, their nutritional status. Do they have enough protein to facilitate healing on their way out? And do they understand that that's going to be important for them in the next recovery period? Skin preparation. When somebody goes into surgery, we might have them take a what they call a chlorhexidine bath, or a shower and scrub with that the night before, the morning of, and then we do that immediately prior to their procedure. Although preoperative nurses sometimes will shave the patient, it's never with a straight razor. It's always with an electrical razor. And that's usually done actually in the operating room, not by the preoperative nurse. So the best practice is to do that immediately prior to cut and skin prep. Then the skin prep happens before the incision, of course. Bowel preparation for a lot of GI procedures or colonoscopies, those types of things, there'll be a bowel prep. And so we try to clean out the intestines from any kind of unnecessary stool, depending on what needs to be done. Urinary elimination, depending on the length of the procedure, sometimes we will insert a Foley catheter. For things that are like less than 2 hours, generally what we do is we have you use the restroom before you go in. And but if it's after 2 hours or longer, then you're going to need to your bladder's still making urine, so you're going to need to have that relieved so that we don't create a situation where your bladder is too full and you're not conscious, and that can create complications. We're going to give you preoperative medications. We might give you something to calm you down, maybe a little bit of Valium, or we might give you Zofran, which is an anti-nausea med. We might give you scopolamine patch, which is also for nausea. There's a whole post-operative nausea and vomiting protocol that includes corticosteroids and all sorts of things that anesthesia will use to decrease your chance of post-operative nausea if you have some of the risk factors. Some of the risk factors are kind of random, female, smoker, have had children, some really interesting things. So anesthesia is very comfortable with that. Routine medications we give during the OR, we give antibiotics, and that antibiotic is hung on every patient immediately prior to incision so that it's in the blood at the time of the surgery, which is kind of interesting, right? It has to be there right then. And then we'll continue that afterwards if necessary. We also use a lot of narcotics, of course, and regional anesthetics, so lidocaines, et cetera. That's more common now because we're trying to reduce the use of narcotics whenever possible. And then prosthesis, if there's somebody that requires that, they might be fitted with that actually in post-operative care. So whether it's a breast reconstruction, maybe there's a prosthesis, or maybe an amputation. So that might be part of the care. We use leg squeezers or sequential compression devices, or even just TED hose that keep that blood from getting stagnant in the calves because you're not walking. and your compensatory mechanisms are impaired during surgery, so that blood may not be moving as fast as it usually would, especially since you're laying down. Handoffs. Handoffs are extremely important in surgical care. Many errors happen during the handoff process. So we're very careful when we transfer a patient, and we have a full report on every venue change from pre to intra to post-operative care. And we're careful about how that information is presented. And we use a lot of SBAR in that communication. And then when you transfer the patient to the operative suite, that's a very important transfer because you are communicating what has been done and what hasn't been done. And a miscommunication at that point can result in an error. There's a lot of redundancy in this process to make sure that we're not missing something. Okay, preoperative communication with the surgical team. The most common cause of medical errors is communication failure. So good communication, including things like receiving a summary of the plan of care, speaking up and being assertive with concerns, and the respect of that when it occurs, the stop the line mentality. Everybody needs to listen and realize that there's an event. Ask questions to clarify confusion. Acknowledge that they've heard it and that they understand it so that they can indicate a clear communication. Use standardized terminology. So use things that people will recognize so that there's not confusion there. And then we use a surgical safety checklist as part of our verification process. All of those things are imperative in preventing communication problems. The other thing I'll say about communication problems is it's largely a cultural phenomenon, right? So it doesn't take a whole lot for an interaction between coworkers or between a surgeon and a nurse to inhibit the chances that that person will speak up in an error. So I might be working with a surgeon that I really like, but twice last year I did something wrong and he yelled at me. Well, I might be less likely to communicate that as opposed to working with a surgeon that tells me every time we do our timeout that I'm a human being and I work long hours and I need your help in making sure that I don't make an error, right? Big difference. And the cultural aspect to that is not a small thing. Intraoperative phase. So when you're in the OR, here's who the players are, okay? So number one, you never really think about this, but you have your sterile team in the operating room. So you have your surgeon, your surgical assistant, and the scrub person, and they're in what we call the sterile field. And that's about a 4x4 section of the patient where everything is as sterile as it will be. There's a whole process for being sterile. Doesn't mean it's perfectly sterile. Skin cells come off of the people over the wound and things like that. And so we're always careful to try to minimize that. And so you have your scrub nurse and you have your RNFA, you have your surgeon. They're all at the elbow and they're all working there. You have your clean team, which are people that are not sterile. They are running, like for instance, the circulating nurse is free to facilitate anything that's not on the sterile field. Anesthesia, of course, is monitoring the patient's airway constantly and cannot leave. But the circulating nurse oftentimes will go grab supplies. They don't leave the room whenever possible, but because they're advocating for the unconscious patient. The other people that we don't talk about in the intraoperative phase are people like the central supply or the sterile supply. These are people that are preparing instrumentation sterilely. And so those are the people that send the instrumentation up, and their job is very difficult, and they are some of the lower trained personnel. It's often an entry-level job in the operating room. They have a very important job. So we're starting to realize how important their job is, and that we need to change the way we value that team so that we can make sure that they're as well trained and as important as they really need to be to indicate that our patients are getting sterile items and we're doing things in a safe way. All right, so what happens in anesthesia? So anesthesia providers, they have a great job, really cool job. They're very technical and very talented. And anesthesia is not a science; it's more of an art in some ways. So general anesthesia is the one that's going to put you out. Okay, A lot of people talk about conscious sedation and they say I was under anesthesia. That's actually not the same thing. General anesthesia has the highest amount of risk. You are completely unconscious and you are unable to maintain your own protective mechanisms, things like gag reflex, and even in some cases breathing. So the anesthesiologist takes care of all of your life critical body systems, right? Breathing, your heart and your blood pressure and things like that. Conscious sedation is something that a nurse and anesthesiologist can only give general anesthesia. Nurses can actually provide conscious sedation. It's actually more commonly called procedural sedation today. And that is where you would use a narcotic and maybe another type of like sedative, like a Versed. And between the two of them, they have a synergistic effect. And depending on how much you give and what the patient's condition is, that might put them into a place where they are almost unconscious. But the important distinction is they maintain all of their protective mechanisms, including their gag reflex, including their breathing, and including their ultimate consciousness. They may not remember anything, but they were actually awake and can talk in some level. So you can communicate with them most of the time. When that goes over the line and they start to lose that compensatory mechanism, that's when you have more of a rapid response situation or where anesthesia has to come in and take over. Regional anesthesia is something that we use to numb the area, okay? So if you've had an epidural, if you had children or a spinal, that's numbing your spinal, your spinal cord, and it numbs it down from an area that you inject into the spine. There's also things called peripheral nerve blocks where they can block a nerve in my sciatic nerve and it will numb the entire left leg. Okay, so those are things that we do and that can be very effective, particularly if you have a continuous pump. You may not use any narcotics for a total knee replacement. So it's pretty dramatic when we can do that. The issue with peripheral nerve blocks is it often takes a dedicated anesthesiologist to do that outside of the normal operations. But I think that's becoming an accepted practice more and more that you have to have somebody doing that full time. And then local anesthetic is just making sure that you're blocking a finger for a nail removal, or you're squirting it into the inside of a wound to numb that. And those things are routinely used as well. As far as intraoperative care, the first thing that you're going to have happen, well, actually, that's not true. When you get into the operating room, there's going to be different things that you do. Intraoperative safety measures. First, we're going to ask you who you are 150 times probably. And we're going to check your wristband 150 times. And we're going to ask you what surgery you're going to have and your history. That's all part of the universal protocol. And that's a verification system to make sure that at every point of care, we're verifying that that's the case. If that conversation on what we're having done doesn't match with the consent at any point, we stop the line, right? And that's an indication that something catastrophic could be coming, and we take that very seriously, and that prevents a lot of errors. Right, but when you're starting to go unconscious, we start to position you, and positioning in the operating room is extremely important. It is the source of many injuries and many lawsuits. When your compensatory mechanisms are no longer effective, you lose the ability. You probably never notice this, but when you're sitting in a chair, you're routinely, unconsciously shifting your weight, right? And the reason you do that is because you have to change the circulation in your tissue. Otherwise, that tissue will ultimately become deoxygenated and will die or become damaged. When you're under anesthesia, you don't have that ability. And so we have to be able to pad areas so that that pressure isn't high, or rotate you so that you have the ability to prevent that from happening. And it's not very difficult. It can be as simple as you having an arm in an unnatural position for a period of time, and that can damage a nerve in your brachioplexus, and you might have problems with breathing from that point on. So these are all very serious things that are very easy to miss. And so that's a very important part of what we do. After we position you, we will start to drape the patient sterilely. But before we do that, we're going to prep your skin. So we have a very specific way that we prepare the skin, not unlike the way we would do a Foley catheter. And we prepare that, and then we put the sterile dressing over that area in a pre-specified manner. In the postoperative area, you're going to come out of the OR, you're going to be escorted by anesthesia and by the circulating nurse. The rest of the team is probably getting ready for the next surgery, cleaning up the room, and preparing their charts and interviewing the patient, et cetera. But the circulator and the anesthesia provider are going to come out and give report to the postoperative care nurse, who is going to cover the watch over the patient's airway and physiologic condition from that point on until discharge most of the time. So they're going to talk about what happened, and the nursing care in the PACU is going to be mostly involved in making sure that the patient's protective mechanisms are return, and we watch them until they safely do, and that we can teach them and prevent their pain so that they can transition home as effectively as possible. So when we're monitoring patients in the operating room, we monitor them and we pull a set of vital signs every 5 minutes, and that's a standard. When they get to the PACU area, we do it every 15 minutes for an hour essentially, and then we do every hour after that, unless something changes physiologically. But we monitor the airway constantly, particularly in the first 15 minutes. And in the first 15 minutes, we'll have every 5 minutes. So we'll be in the first 15 minutes, especially, or until the patient emerges or wakes up, we're going to be at that bedside one-to-one care. We're not going to leave. Okay, so you might be at the bedside. You're monitoring the fact that their airway is clear and they're not obstructing. You're watching for their level of conscious. You're watching their vital signs to see what the trends are. Once they start to awake, you can test their mobility and sensation. You're always watching their fluid balance to make sure they have enough fluids. And then you're looking at their dressing and drains if there was a surgery that required an incision. Okay, so last couple slides, post-op analysis and nursing diagnosis. When you have a post-op patient, here's the things you're thinking about. Number one, delayed surgery recovery, right? Maybe there's some kind of knowledge deficit or infection or immunocompromised state that might affect that. You're thinking about, of course, acute pain, activity intolerance. Maybe they can't walk for the first few weeks, and that's going to be something that they need to plan for. Anxiety, of course, is going to be an issue. Nausea, we talked about that as far as postoperative nausea and vomiting, which, by the way, is also a huge patient dissatisfier. So we try to prevent that, of course, as well. Constipation. So when you go into surgery, you're nothing by mouth for a period of time before surgery. Oftentimes, what that means is that you're not ingesting any food. You're also probably having bowel movements. And so your intestines aren't going to have a lot of substance in there. Not to mention there might be air introduced into that area. And so you might have a period of time where postoperatively you don't have a bowel movement. You might even have pain from the air that was injected into there. And you're also taking narcotics. So that's a big problem with postoperative patients. And we address that by drinking lots of water, minimizing narcotics, and getting the patient up and around as soon as possible, which helps that gastric motility return. And then finally, urinary retention. If you had a Foley catheter, we want to try to see you urinate before you leave so that we know that you don't have any retention. That's not a critical thing that's needed, but whenever possible, we try to see that. And if you were to use the restroom after your surgery, and I would definitely chart that you had completed that. Second to last slide is family teaching for post-op patients. So we're going to talk about the incentive spirometer because that prevents atelectasis. Between the incentive spirometer when they can't walk and walking, that will prevent most of those issues. We try to prevent embolisms by using stockings and compression devices. We use GI suction whenever possible to help decrease fluids in the mouth and things like that. We have them do turn, cough, and deep breathing exercises if necessary, and how to do that if they're going to be stuck in bed for a while. Ankle pumps and quad sets. So whenever somebody is post-operative, if they're able to be around, or even if they're just sitting on the couch, there are things you can do to move that blood around, right? One is stepping on the gas in your car. And then the other thing is quad sets, where you just flex your quads intermittently. And a good way to do that is to tell them to do it every commercial. And then finally, we move you in bed. If you can't get out of bed, maybe you can roll to one side or another. You can raise your head higher or lower. And all of those things help your respiratory compliance and change the position. And those all decrease your chance for things like pneumonia. So speaking of pneumonia, here are the things that you can see as complications. And this is our last slide for the day. Respiratory complications would include atelectasis, which is essentially the closure of the alveoli. Those balloons get stuck closed. Pneumonia can also occur either from infection or from mucus that hardens in those alveoli when that happens. A pulmonary embolism is a potential risk of surgery, as well as hypoxia. And so hypoxia just means that somebody didn't identify the fact that your protective mechanism for your breathing wasn't effective and didn't intervene. So hypoxia can be an issue as well. From a circulatory standpoint, it's mostly around fluid status and venous stasis, okay? And sometimes dysrhythmias, depending on the risk of your surgery and the type of surgery. As far as neurological, of course, like emergence delirium is an issue. Maybe you're confused, especially in older patients. Cognitive decline in older patients, it's hard for us to tell what their baseline is. And then also neurological, a lot of people don't think about this, but when they have regional anesthetic, assessing their strength and their sensory abilities again. The GI patients are at risk for things like decreased GI motility because of the reasons I talked about, nausea, vomiting, and then what's called a post-op ileus. So that GI system doesn't wake up at all, and then you start eating, and that food doesn't move through. It rots, it doesn't move through, and it creates a lot of intestinal problems. And then the other two are urinary, which is mostly about can you go, and are you having any issues with incontinence? And then finally, skin. We talked about positioning. If you have skin damage due to a positioning injury, you might be at risk for skin breakdown or wound infections or nerve damage. And that's all we have today. I hope you've enjoyed perioperative nursing.